We just want to welcome everybody here today. We're so happy to have you with us. I want to tell you just a little bit about the gallery because it is a pretty unusual place. So we are a non-commercial social justice gallery. And what we do is we partner with social justice not-for-profits. In this case, it's Human Rights Watch, and that's what the exhibit is over here. And then during the time that the exhibit is up, we have a series of programs that relate to the organization and to the exhibit. The whole idea here is that we can be the artistic voice for so many of these not-for-profits. We've been doing this for 5 years with this mission, and every year we have about 4 different exhibits and probably 50 or more programs. And so I would invite everybody here to sign up on the sheet in the back and join our mailing list, and we will inundate you with invitations to programs. And so please do that. We host a lot of events, and we love hosting events. But this one is really very special for us because Kim and David, who own SunCloud Health, are my stepson and daughter-in-law, and it's just so exciting to be able to play a part in the great work that they're doing. And so with a special welcome, we're going to get the program started. And so here is David to kick it off.
Well, thank you very much. I'll be very brief. I just want to say, most importantly, thank you, of course, to David and to my mom for allowing us to have this event here. It's really just a pure privilege to be amongst, the organizations that they support. David, I've seen you, go from a businessman to an artist and just a true inspiration. My mom, same to you. SunCloud is very much committed to social justice issues. Dr. Kim, who's my wife and founder of the organization, or co-founder, is a true inspiration to me as well. And so I think that this is a great place to have this event, to just, like I said, to be in the same company as the organizations that David and my mom represent and support is really just an honor. So I will turn it over at this point to Kim and Marcia. And again, thank you all for being here. One last note, the Kennedy Forum, which many of you are familiar with, has some materials, and please visit them in the back. It's a great organization as well, and just know that they're here. Thank you.
So welcome, everyone. I'm Dr. Dennis, Kim Dennis, and I'm so grateful to be here. Very grateful to David and Jerry for generously allowing us to have this particular presentation in this space, and I think it lends itself nicely to what you guys do here day in and day out. It's okay. Welcome to the Kennedy Forum. I'm a board-certified psychiatrist, and I spent about 10 years helping to launch and sustain a treatment center, Timberline Knolls, before transitioning over to SunCloud Health, which David and I started about 3 years ago. And we provide partial hospitalization, intensive outpatient, and then ongoing aftercare for people with complex co-occurring disorders that tend to fall through the cracks at institutions that focus on just one disease state. And I've known Marcia Nickow, Dr. Nickow, for about 15 years now. Yeah. I don't even think I think I was in medical school when I met Dr. Nickow at a group relations conference. So I'm very, very grateful to be presenting with Marcia. Well, part of what we'll do here today is have a demonstration group. And it's not every day that I get to co-lead a group with Marcia, so it's always a good one when I can. Before we start, I'd like to just do little survey of who we have here in the audience. How many of you guys are therapists? Therapists, okay. And of the therapists in the room, how many of you have addiction training? Eating disorder training? And how many of you provide trauma-specific treatment? Wonderful. Any people here from Human Rights Watch? Okay. Nisha, if you would be so kind as to stand up and introduce yourself and just tell us a little bit about who you are and the work that you do there.
Thank you. My name is Nisha Varia. I am in the Women's Rights Division at Human Rights Watch, which documents human rights abuses in over 100 countries in the world. And as part of my work, I've developed the guidelines for our staff, over 100 researchers who are working in conflict settings and institutions in very poor and rural areas, about how we can conduct our research interviews in an ethical way, because we are often interviewing survivors of trauma.
Wonderful. Thank you so much for being here and for all of the work that you and Human Rights Watch do. So we'll get started. The specific talk that we're going to give today is really about how we, as organizations that treat vulnerable populations, can put safeguards into place so that we're not participating in re-victimizing those patients, those clients, those people. Marcia and I decided after the sexual abuse allegations came out at Timberline Knolls that we would launch a series of trainings to help institutions and organizations look at what safeguards we can put in place and what our role is at all levels of organizations in perpetuating trauma. We know that hurt people, and hurt organizations or unhealthy organizations in a variety of ways can end up hurting people. I think we'll start with a few definitions. We'll talk a little bit about characteristic responses to trauma, including cultural responses to trauma and organizational responses to trauma, characteristics of a trauma-informed treatment center and what some of these safeguards actually are. Dr. Nickow is going to give a detailed clinical case, and then after that we're going to launch into a demonstration group, which will be comprised of 8 volunteers from the audience. And the purpose really of the demonstration group is to demonstrate how on a ground level, rubber hits the road level, we actually put trauma-informed principles into action in our clinical supervision model that we have at SunCloud Health. And then we'll open it up to a discussion at the end. One of the things to be aware of, we have people filming. We're going to stop the filming once we do the demonstration group so that people are more open to sharing, and it's a trauma-aware way that we're going to invite you to participate in the group. So after we finish the PowerPoint piece of this presentation, the lights will go back on and the cameras will go off.
One thing to keep in mind is that if we have really great trauma-aware and organizationally safe principles in place in our facility, if we also interact and interconnect with other facilities that don't have that, we can set our patients up for re-traumatization right during their treatment process. So that's one of the things that we're really interested in helping to prevent.
Right. Yes. Yeah, I mean, part of the purpose of this is to get other organizations really interested in how we, as the caretakers, the caregivers, the advocates, can inadvertently participate in people's ongoing traumas. And there's very little written about this. There's a book from 1989 by William White that talks about it a little bit, and very little in the research literature that looks specifically at how organizations themselves participate in re-victimization of vulnerable populations. And we'll go quickly through the PowerPoint piece of this. I think most of you already have a fair amount of knowledge about what trauma is and how it manifests. So we like to define trauma with the 3 E's. An event that is deemed traumatic or overwhelming, both physiologically and emotionally, to an individual. So it's individualized. It's dependent on the individual's experience, not an objective standard. It's experienced by an individual physically or emotionally as harmful or threatening, potentially life-threatening. And the effects on the individual impact that individual's functioning on a neurobiological level, on an emotional level, on a social level, and on a spiritual level. These events can range from something like being in a motor vehicle accident, being exposed to war, natural disasters, and then interpersonal traumas, such as abuse of power, special relationships, incest, physical abuse, growing up with a serious medical illness in the family, growing up with alcoholism or mental illness in the family, all are considered traumatic events. And the scope of the problem is enormous. This is a problem that victims don't talk about it. Institutions are set up to support and foster the don't talk rule. So the data that we do have shows an enormous problem, and every person who's ever worked with traumatized populations knows that these data are most likely an underestimate, a gross underestimate. So what this slide shows is, in the orange, 52% of this was a population-based survey on adverse experiences in childhood. 52% of people said they had none. I call that denial. I spend a lot of my time as a therapist peeling away, seemingly year after year after year, layers of denial. 25% said they've had one adverse family experience, probably, again, some denial in there, or maybe we'll call that minimization. And then 2 or more adverse family experiences in another quarter of the population. And not everybody who experiences trauma gets into treatment. Not everybody who experiences trauma develops DSM diagnosable post-traumatic stress disorder. And that does not mean that people who don't have PTSD are not still affected by trauma and are not perpetuating that in the workplace. And when they're perpetuating that in a workplace that specifically deals with helping vulnerable populations, traumatized populations, is where we can have a perfect storm for some disastrous outcomes. The traumatic experience is often met with confusion, shame, humiliation, betrayal, and silencing. Many victims that I speak to talk about the silencing and the shame as the most damaging aspects of what they've gone through. The experience is impacted as well by a person's resilience factors. Both vulnerability factors and resilience factors play into the impact that a trauma or many traumas have on a person's development. Adverse effects may occur immediately or delayed. People always say to me, how is what happened when I was 5 relevant to me, having to drink 5 beers and 5 glasses of whiskey every night at the age of 40. Like, that was 40 years ago, 35 years ago. Sometimes people have traumas that emerge and old traumas that emerge when they're met with life stressors in adulthood. Transition to college, firing from a job, divorce. Many times with women who are sexually abused, harassed, raped, one of the arguments to keep the woman silent or keep the woman in a place of shame is, well, if it really happened, she would have said something 10 years ago, or 15 years ago, or 20 years ago, or even 3 months ago. And that's just not how our culture is set up. We're not living in a culture that supports people who are victimized to immediately speak to it. And neurobiologically, people who are victimized are caught in a brain system. It's literally built and hardwired into their brains, a dissociation response. And there's a lot of silencing and there's a lot of freeze in dissociation. So there are many barriers for victims to talk about what's really going on. Some of that is cultural, some of that is interpersonal, some of that is intrapersonal and neurobiological. A few of the key definitions that we're going to talk about. Reenactments. What is a reenactment? We hear this a lot in psychoanalytic, psychodynamic therapy. It's the acting out or repetition of a past traumatic event or situation. So that can look like a person who has a history of incest ending up getting involved in a therapy with a therapist who crosses sexual boundaries. That would be a reenactment. Repetition compulsion is an unconscious process whereby the trauma is repeated in later life scenarios. So people who end up, the person whose dad left the family at age 5, who ends up marrying guy after guy after guy who's not there or who leaves. And this is a psychoanalytic term, repetition compulsion, and when I talk to patients about it, I'm very careful that I'm not, you could read this definition and think, oh, she's doing it to herself, right? So you can use that definition to sort of shame the victim or perpetuate the false belief in the victim that it's all her fault. Boundary violation is a crossing or a disruption of the barrier between a professional and the client. This can also happen in organizations. So between the boss and their subordinate, between an administrator and the clinical staff. And these come up all the time. I think it's important to realize that it's not, like, the purpose of this presentation and these series of presentations aren't to make reenactments go away. Reenactments are going to happen, and they're going to keep happening, and they're actually quite useful if we use them in therapeutic ways rather than use them in ways that end up perpetuating the harm to the victim. Abuse of power. I think we've heard a lot about this in the wake of Me Too. The McDonald's CEO was fired a couple days ago for having a sexual relationship with an employee. Whenever there's a power differential, even in two consenting adults, there cannot be consent in the way that consent is a safe thing for two people on an equal playing field to engage in some sort of activity. So some of the effects of childhood trauma and reenactments that people perpetuate on themselves and experience in interpersonal relationships include compulsive self-injury, compulsive eating behaviors, overeating, undereating, binging and purging, addiction, compulsive use of alcohol, drugs, food, sex, work, internet, gambling, compulsive exercise, special relationships, and sex and love addiction issues. And all of these, many times people who have never experienced compulsive self-injury themselves will say, why does she do that to herself? It's very hard for somebody who hasn't had the experience to understand why a person would do that. And it really is, at the end of the day, to have a sense of control, to have a sense of safety and a sense of security by using an external means. Revictimization is the rule rather than the exception for people who've been traumatized early in life. Violence towards others can also be a part of how trauma plays out. We know that people with experiences of childhood sexual abuse are 2 to 3 times more likely to report rape as adults. Twice as many women with incest histories report domestic violence in their marriages. Twice as many people with childhood sexual abuse report unwanted sexual advances by an authority figure, whether that's a coach, a teacher, a boss, a clergy person. And what a lot of the studies show is the factor that mediates how the extent of revictimization is the extent to which that person dissociates. And dissociation can really become a way of showing up in the world. It's not a conscious thing. Victims don't decide to dissociate. But when our brains are developing from the age of in utero to 25, and a person experiences repetitive trauma, the brain develops around, and the neural pathways develop around a defense and a response of dissociation. And what that looks like later in life is doing whatever you can to stay in that dissociated response. So drinking, overworking, starving yourself, binging and purging, avoiding the whole world. Common cultural responses to trauma that we see also by treatment professionals who are not only trained but assigned the task of helping victims recover from trauma are denial, minimization, rescue, victim blaming, vilification, and hero worship. I haven't met a therapist that when somebody is sharing a history of sexual abuse has not had the experience, at least with one patient in their whole history of treating patients, where they've thought, did that really happen? Or is this person, is this really true? And even if we don't say it, because our patients are exquisitely sensitive to what we're feeling, to what we're thinking, to our energy, they know it and they sense it. And clinical examples in treatment centers include abuses ranging from microaggressions directed towards marginalized populations, racial minorities, the trans population, the LGBT population, benign neglect, which would be like if I'm a physician who treats people with eating disorders and somebody's binging and purging 5 times a day every day and I haven't checked their electrolytes in a month. That's an abuse, and that's a neglect. And a lot of times that's a reenactment. Boundary violations involving time boundaries. We've committed one of those already this morning. We started 10 minutes late. So part of the safeguard that we'll talk about is making things speakable and being explicit about what we're doing. Don't want to sweep that under the rug. Abandonment and enmeshment, either distancing from the patient as a defense mechanism, which happens a lot with chronically suicidal patients or patients who have chronic illness, which is about 1/3 of patients with addiction and eating disorders. And many times these are patients that get sent from treatment center to treatment center to treatment center because we want them to get the best care and make progress. But really, it's because clinicians have a really hard time sitting with our own limitations on the limitations of medicine and the limitations of psychiatry. Special relationships, and Marcia will talk a little bit more about that in her piece. Role diffusion or lapses in role. I have a patient whose psychiatrist, this is a physician patient whose psychiatrist asked her to do part of a physical exam on her knee. And this is a physician who was seeing this psychiatrist for her trauma therapy. Mismatch between role and experience level. Many times in organizations, people are set up in positions of authority that they're not trained for or that they don't have the experience to actually succeed in. Abuse of power and sexual abuse. I'm going to turn it over to Marcia to go over the clinical case example, and I'm going to just forward ahead to a piece of it. She will inform you of the rest.
So the clinical case example that I wanted to talk about is Dr. Bessel van der Kolk. He is very well known. Most of you probably have read some of his work. He's a trauma researcher, author, psychiatrist. He has a worldwide following. When I used to teach to doctoral students trauma therapy, we used tons of his stuff. The Body Keeps the Score Now, his famous book, was an article that developed into another article. And he's just done some groundbreaking research all along the way. He's revered by many of the mental health disciplines.
People that have encountered him, I encountered him in a few conferences, like the American Group Psychotherapy Association and the International Society of Traumatic Stress Studies. And people who have encountered him, including me, note some abrasiveness in the way that he interacts with people. So that always made me wonder, and yet, I really respect his work, as do many of you. He gets it in many ways about trauma. And he was fired. And a lot of stuff happens in secret, like Dr. Kim was saying. I still call her Dr. Kim. But a lot of stuff happens in secret, and our profession, we mirror what happens in the culture. And this was a lot of the information that I got was by being on a psychodrama listserv. There was an article in the Boston Globe, but pretty soon everything goes under, and I think it's really important. We think it's really important for us to make things speakable that are going on a macro level too, because it affects all of us. And so he was fired in January 2018 from the trauma center in Boston. There was like a tumultuous few months there, and he had helped found that center like 35 years before that. It was very famous. He was still working there 16 hours a week when he got fired. And this center treats patients, adults and children. And it also trained, like in a 5-year period before he got fired, it trained about 20,000 people in psychotherapy, play therapy, body-centered therapies, such as yoga. And so lots of people are impacted by what we don't know the details of what was happening, but he was fired for, quote, creating a hostile work environment, bullying, and making employees feel denigrated and uncomfortable. And so what we have here is abuse happening in the workplace by someone who is a great researcher and advocate on abuse and preventing abuse. The person that really took a stand on this was the president of the JRI, that was the parent organization of the trauma center. And this all came, we could pretty much hypothesize that the whole Me Too movement impacted people's willingness to come forward and use their voice, because the timing was such that just as all of that was coming out, things were coming to light at the trauma center. So it was like 3 months after all of the allegations against film producer Harvey Weinstein sparked the whole Me Too social media movement. And within that 4-month period is when 71 men in power and entertainment and news and politics and sports were accused of sexual misconduct, and most of us follow that really closely, fired, resigned, or experienced similar professional fallout, whatever that be. And the New York Times said, in what appears a seismic shift in what behavior is tolerated in the workplace, a cascade of high-profile men have since been fired or forced to resign. In high-profile situations, the focus has been on men so far. I think that there's going to be a lot coming out on women too, from what I've experienced in clinical practice over the last 30 years, the things that don't make it out there, but that we hear in our consulting rooms. And one of the things that touched me about press reports was a quote from Barry Lubin. He was one of the people that got charged. Grandma the Clown for Big Apple Circus. He was accused of sexual harassment of a female minor coworker. And here's what he said. I never heard another apology like this in all of the media reports. Grandma the Clown said, "The allegations are true. What I did was wrong, and I take full responsibility for my actions." Okay, now that's an apology. How many times have we heard that as we were watching people get targeted, accused, and hearing their defensive responses? It was in March 2018 that the Boston Globe reported Vander Goek's firing in an article headlined "Allegations of Employee Mistreatment, Royal Renowned Brookline Trauma Center." And it turned out that his executive director, who I spoke to a few years back when I was at Timberline Knolls, also a longtime advocate for abuse victims and involved in a lot of the trainings that Dr. Vander Goek did, he was removed in November for mistreating female employees. And Pond, the president of the JRI, said he terminated Spinazzola for violating the code of conduct in his treatment of women and more broadly for abusing his power as a talented and respected figure in our field. Like someone's breaking a code of silence, a conspiracy of silence that we have in our field too, and just coming out with it. And he also told staff in an email, no one is denying the impact that Bessel has had on the world, but a professional workplace has rules, and no amount of talent or skill excuses violations of those rules. And so, like, what we clearly have in our country is a culture of workplace abuse. Like, it's very common, and so it has to come to light, and we can play a part in that. Anyway, I was really shocked when I read in one of the listservs Dr. Vanderkook's letter to the trauma center. Here's the letter, because this is someone who's like a wizard in areas of trauma. Dear Trauma Center colleagues, as you can imagine, I am devastated reading the allegations in the Boston Globe that I have been bullying and denigrating my colleagues at the Trauma Center. I am also aware that such accusation cannot be entirely pulled out of thin air, and that some of you must have felt bullied and denigrated by me, though as far as I remember, listen to this, none of you have ever confronted me with such misbehavior. Okay, like, what do we know about victims? Like, they don't come forward unless there's a real safe environment to do that. If I have inadvertently denigrated or bullied any of you, I would like to know about it, apologize, and make amends. As you know, I'm a strong believer in doing your own personal work, and in my book, a little promotion here, The Body Keeps the Score, I describe some of that journey for myself, including with Dick Schwartz in internal family systems therapy and with sensory motor work in disguised form. Okay, but as the record now stands, a little victim-y coming here, I will forever be remembered as the trauma therapist who traumatized his colleagues and who founded and ran, a toxic environment. Somebody who talked a good game, but who is just a Harvey Weinstein in disguise. If you feel that allegation is correct, consider justice to have been done. If not, I hope you will consider being vocal in public about how you feel about character assassination and speak your truth. Okay, so here's what we have, and I think it's really important because honestly, I've been, pointing out a lot of stuff. Pardon me? Say that? Yeah, exactly. It's hard. I don't mean to make fun of it. Like, I felt super sad reading all of this. But I think that it's really a good example of what we really have to look at, how entrenched these attitudes are, that someone who has all this intellectual knowledge will come out with all of this, yes, devastatingly yours, and, I'm the victim here. Who else? Who are the real accusers here? Will they come forward? And then also inviting people to start a campaign on his behalf. So also, Then he wrote a letter to friends that I had seen a copy of and said that JRI has engaged in the public character assassination of me that most of you have by now heard about. That is not to say that I cannot be impatient at times, and I have been known to be harsh. Okay, here's minimization. That's something that I've been working on in my own therapeutic endeavors and will continue to do. Okay, but we can't abuse people and use, I'm working on it as a reason that makes it okay to justify. Another thing that shocked me, Tia Dayton, who actually, I had used a lot of her work in my dissertation research on trauma and resilience, but she jumped in right away on the listserv with how, to express her dismay at the firing, and she talked to Bessel. And then she's talking about how her only dealings with him have been that he's so nice, real easy and fun and brilliant, of course. His wife came to one of her psychodrama trainings and did a wonderful job. And I just felt there's self-interest. Okay, a lot of self-interest. This makes it okay because you met his wife and they're nice people to you, and that, she was very excited too because he used to badmouth psychodrama. And think about this with abuse. You learn that to expect a baseline. Now he's not bad-mouthing psychodrama anymore. So now, he's a great being, and we should put to rest all of these accusations. So she also noted that he had referred to her work as fabulous in front of 150 people, just to be kind. And he's a friend to psychodrama. You know, and then I'm watching these kind of comments come in on the listserv all within like 2 or 3 days, and they're out of the blue. There's this one guy, Ed, who I once met at a conference, and he said, while Vanderkook presents himself here as the victim, I would be interested to understand what those who felt victimized by him have to say as well. Okay, which would make this much more sensible to know that. And what happened, though, is that Pond from the JRI said that all the people that came forward, none of them wanted any details out in the press. And so we don't really know what happened. We just know that something did, and he was fired in a very unusual circumstance. And there's a lawsuit that he has going right now, too. And part of it was that the JRI didn't have a right to fire anyone, things like that. But anyway, I think that there was some good responses from clinicians too that I thought were really thoughtful. And it was like, okay, so if I'm recommending my work, his work, to, students, patients, whatever, what do I do? Like, what happens if people ask? Do I keep recommending his books and ideas? In my mention, do I reframe how I speak or write about him? Does his firing change or negate his contributions and research? How might we understand his contributions and his heralded maverick type of attitude of Western psychiatry and traditional talk therapy in light of this recent information? And that touched me because the day that I saw him present at AGPA, it was like, hundreds and hundreds of group therapists in the room, and he's saying, like, talk therapy doesn't work. And I'm wondering about this, and then he had said the same thing about psychodrama, and still his work is great. I love it. I recommend it all the time to people, and I also share this part of what I'm now aware of. And I think that this exists on a number of levels, and Kim and I have talked about Timberline Knolls and some of the abuses that we felt were present there and could see, and that you can't always see it while you're in it, but if you pull some threads and learn, and then it can help us run a very trauma-safe environment today. So, you want to say something? Okay, so thank you all for listening to us about topics that we're real passionate about. What we'd like to do next is have 8 volunteers, like
Marcia,
it could be anyone.
Yeah. So we're going to launch into a demonstration group, but before we do that, it's nice to have the principles of trauma-informed treatment nicely written on a piece of paper, and a lot of places have that. What we hope to demonstrate is a tiny taste of how we do that experientially at SunCloud. But I think it's important to have a sense of what some of the important principles are. So I'm just going to run through a couple of those quickly, and then we'll go into our demonstration group. All members of the organization need to be able to incorporate an understanding of the prevalence of trauma, its impact, and the complex and varied paths by which people heal from trauma. And not just the patients, but the staff, the administration, the owners, all levels need to be involved in this, or it doesn't work. 3 key practices are realizing the prevalence of trauma, recognizing how it affects everyone involved in the institution, and responding by putting this knowledge into the policies and practices that actually happen day to day, not the policies and practices that happen a couple days every 3 years when Joint Commission is in the building surveying you. And 4 key elements, which come from some of Bessel van der Kolk's work with traumatized children that have been shown to help traumatized children more than anything else, establishing a sense of safety, and that means physically and emotionally in the organization, structure, providing structure, consistency in that structure, and nurturance. And some of what that looks like is if I'm running a men's group at 12 o'clock in Northbrook today, which I am, I'm going to be leaving here by 11:15 and getting there and starting the group on time, and I'm going to end the group on time. Deviations from that, we also strive for balance, and there are times clinically when we may need to go a little longer. But wild deviations from that really interrupt a person's capacity to trust and sense safety in the organization. And there are 10 principles that are widely used. Some of these come from SAMHSA. Many of these come from SAMHSA and working with dual diagnosis patients. One of the key ones, I'm just going to highlight the key ones that I see over and over again from patients that come from other settings or from other settings that have different rules. So transparency. There's a rule that happens in sick family systems and sick cultures, and it's the don't talk rule. You know, what happens in this house stays in this house. And one of our core values is transparency, and that's transparency in how we operate financially, transparency in how we operate with patients, in what we're feeling and thinking about each other as members of the organization. And that's very jarring to many clinicians that come to us and start to train with us and use our model. We were remodeling our Northbrook office, and one of the walls had the drywall taken down, so there were just the pillars, the studs, thank you. There were just the studs, and this employee was like, wow, we're so transparent now, we don't even have walls. So it's a real thing at SunCloud Health. And then shifting of power, both as a therapist to patients who feel powerless, disempowered. I can't write a person's treatment plan without their input. If many places do, you just click the boxes and there's the treatment plan. But there really needs to be a shared power and a shifting of power from where it historically is, the white old guy in the corner office, to throughout the organization, in collaborating with employees around what the policies are or what you want to do with this patient, collaborating with patients and families about where they're at and what they're available for. Peer support is part of shared power. Inclusiveness is another key component of what we do. Many places, one of the things that we do at SunCloud, one of the reasons we created SunCloud was because people who have 3 or 4 old Axis 1 diagnoses, an eating disorder, an active addiction, PTSD, and depression, couldn't really go anywhere and get all of those addressed. They could go to Hazelden, get really good care for their addiction, and throw up the whole time. They could go to Eating Recovery Center and get really great care for their eating disorder and be prescribed like 5 or 10 milligrams of Klonopin a day so that they could eat. Or they could go somewhere and get their mental health taken care of, but nobody's really going to touch on the addiction or the eating disorder, and it's all connected. So our clinical model is built on inclusiveness. We don't track people out like the addicts go over there, and if you're an eating disorder, you go over there. And then also in the organization and in groups, we are keenly aware of scapegoating. And how often are patients, the most vulnerable of our population, scapegoated, and they become the problem. And what happens in treatment centers is, well, let's either just kick them out right now, or let's put them on a treatment contract that's unsustainable and impossible to achieve by, like me, I think I'm moderately healthy, and set the person up to fail the treatment contract and send them out that way. Okay, so with those principles in mind, we will launch into a demonstration group with the intention to demonstrate how clinical supervision operates and actually incorporates these principles. And we're going to ask for 8 volunteers. Marcia's going to recruit you guys, and we'll meet as a group for 40 minutes. And then after the group, we'll have an interactive discussion. At this point, I'm going to ask that the filming stops. We're going to use what we've done up until this point for training purposes.